So thanks for joining us. My name is Karen Corman, and I have the privilege of being the Executive Director of the UIC Alumni Association. Welcome to the UIC Alumni Exchange Series. We have just surpassed our one-year anniversary of our first Alumni Exchange, and thank you to all of you that have attended past Alumni Exchange programs. We look forward to continuing to bring you a variety of topics and programs so you can explore, connect, and even escape from the everyday with a community of UIC faculty, staff, and alumni experts. You'll hear me say this a few times today, and we'll go ahead and put it in the chat too, but I encourage you to visit go.uic.edu/alumni exchange for the latest and greatest programming. And before we begin our program, we want to share some exciting news with you. We recently launched UIC Connected, our online networking and mentoring platform. Please enjoy this quick video to hear more about UIC Connected. We hope that you are as excited about UIC Connected as we are. You can go to go.uic.edu/alumni exchange to join today. And we'll go ahead and put that also in the chat so you don't have to remember that link. And with that, I'm excited to start our program this afternoon. We are joined by two distinguished faculty members. First, Dr. Brenikki Floyd, who is a clinical assistant professor in community health and sciences in our School of Public Health, and Dr. Charles McPherson, who is in the College of Pharmacy as a clinical assistant professor. Drs. Floyd and McPherson will discuss the latest on COVID-19 vaccines in this interactive discussion. Thank you to both of you for being with us today, and I'll turn it over to Dr. McPherson to begin the program.
All right, thank you. Just gonna... Okay. Can you guys see my screen okay?
It has not come up yet.
It does not, okay. Okay, what about now?
You can see it, but it's the PowerPoint template versus presentation mode or reading view.
Okay.
I think that will work if it's not going to cooperate. We're now on slide that has the gray slide that says United States COVID-19 statistics.
Okay. And does it, what about now?
We can still see the slides, but I think it's so small, I think it would be fine if you use this.
Okay.
Advance.
All right. So, as mentioned, I'm Dr. Charles McPherson, and I'm one of our clinical assistant professors here in the College of Pharmacy. I currently work in the Department of Pharmacy Practice, and I also am a clinical pharmacist in inpatient internal medicine. So as a part of my job, I round and I see patients every day with my physician colleagues, and I am actually considered a drug expert as relates to the management of our patients in their various disease states. And so I make recommendations about how we can best optimize therapy for my patients and help come up with treatment plans. So with that, I'm going to begin. So let's talk about COVID by the numbers. And I have a few slides where we're going to talk about just some basic numbers or demographics. So number one, we'll take a look at, and this information is current as of today. I try to include the most recent information so that you guys would have that. But as you can see, there's about a little bit more than 32 million cases of COVID within the United States and over 580,000 deaths. And I remember when we reached that milestone of greater than 500,000 deaths and how many news reports were being done on those particular numbers. And it's just unfortunate that we lost that many lives, that many Americans as a result of this illness. In the state of Illinois, there are 1.3 million cases, and we've had in upwards of 24,000 deaths. And then moving on to our state statistics, what you can see is that Illinois, we are in the top 5. We're top 5 in the total number of cases. And you can see highlighted here for you guys, I listed that there. However, as it relates to the total number of deaths, we're actually lower than the states that are ahead of us. And I consider that good news, considering the fact that I know that the mayor and the governor have both concentrated very, very hard on trying to ensure that Illinois citizens, that we remain safe. So we had, pretty extreme lockdown measures and a lot of public campaigns to encourage people to wear their masks and to conduct hand washing. And then we've had a pretty successful vaccine rollout program as well. So the National Vital Statistics System, they release provisional mortality data. This is typically not really done in real time. Normally, we'll find out death rates for various illnesses, typically like a year later, or so, for example, for the year of 2020, we may not find the actual causes of death or the leading causes of death until at the end of 2021, maybe the beginning of 2022. But because COVID has had such an impact on our personal lives, and not only of us here in the United States, but worldwide, that actually the CDC asked that these statistics be gathered. And so as you can see, these are headlines that were created all over the country, that COVID was the 3rd leading cause of death in the United States last year. So it made a lot of headlines in a lot of places. As you can see on this particular slide, COVID actually jumped up to number 3 behind heart disease and cancer, and pushed unintentional injuries down to the 4th place. So again, that's how significant the number of deaths that we had in 2020 with 345,000. It was so impactful that it actually jumped into the 3rd place behind heart disease and cancer. So what is the impact on COVID on the mortality rates? Again, we've talked about the number of deaths that we had. Actually, we feel that these numbers are pretty much underestimated, because you have to realize at the beginning of the pandemic, we really didn't have a very good testing strategy, not just, again, countrywide, but worldwide. There just weren't enough tests available to help us get accurate numbers. Also, you have to keep in mind that as it relates to those other causes of death, like heart disease and unintentional injuries, we saw increases in the number of people who suffered demise from those particular illnesses. And we think that that's due to disruptions in the healthcare system. So again, going back to your memory, if you guys remember, once COVID hit and we went into shutdown, the ability for us to go to the doctor, to see our primary care physician, became compromised. So people who normally would have gone for routine checkups, people who were being treated for cancer and many other different diseases, were no longer able to go directly to their primary care doctor to seek help. So in all of that, there has to be some good news, right? Normally I would save this to the end of the presentation, but what I wanted you guys to know today, early on in the presentation, is that there was good news, or there is good news that have come of this. Right now, or as of today, in upwards of 35% of Americans are fully vaccinated against coronavirus. Keep in mind that this number changes daily as we see more Americans become confident, they develop vaccine confidence, and so they're opting to get vaccinated. Now, there are challenges. I will talk about those challenges, but so will my colleague, Dr. Floyd, who will be coming on in the second part of this presentation. So again, 35% of Americans fully vaccinated, Great news. At least 46% have received one dose, and 58% of adults have received one dose. Biden's goal, you guys may have heard this in the media, is that 70% of adults have at least one shot by July the 4th. And to help with this campaign, Uber and Lyft have signed on, and they will be providing free rides to those who need transportation to vaccination locations and vaccination sites. So how does that compare, or how does that relate to Chicago? This data is current as of April the 27th. I don't have more recent data than that, but the mayor was proud to announce that we've actually administered 2 million doses. And so she had a huge press conference when this occurred. And I agree, because Chicago has been doing a great job. We do have a lot of vulnerable populations, you know, within our city and within the county of or Cook County. And so the fact that those things have been taken into consideration as we roll out our vaccination strategy and our program, I think that that's a great thing. So kudos to the city of Chicago. And what does that mean for UI Health? Because I know that many of you guys are alumni here. So basically what that means is that, and some of my words fell off here, is that UI Health is working with Credit Union Arena as the mass vaccination site. The College of Pharmacy, where I work, is also a vaccination site or location. As of May the 7th, we've administered over 102,000 doses, and the University of Illinois Hospital has a robust vaccination program for our hospitalized patients. And with the recent emergency use authorization of the Pfizer vaccine for children of ages 12 to 15, we have added them to our inpatient protocol. So what does this mean? It means that patients who are hospitalized for any reason, again, we have a protocol in place where we will approach them and ask them if they're interested in receiving a vaccine. Because again, we are committed to the city's strategy and the city's efforts in trying to vaccinate all of our patients. So with the COVID vaccines, how did we get here? Well, there was a roadmap for development. And this roadmap basically looks like this. So normally with vaccine development, it can take in upwards of 10 to 15 years to develop a good vaccine. The mumps vaccine, which was marketed in 1967, which up until this point had been the fastest, or one of the fastest, it took 4 years to develop. So keep in mind that when we began to do the research, and I'm talking about the scientific community here on the vaccines, and I have some slides that focus on that, President Trump announced that there was going to be something known as Operation Warp Speed. I actually wish that he had not used that particular terminology, because I think that it may have contributed to people feeling that the vaccine process, the development process, was being rushed. But nonetheless, that was the name, Operation Warp Speed. So our government invested billions into the vaccine development process. So money was given to pharmaceutical companies, not only for technology, but also scientists were being lended to those companies to help them or assist them with the vaccine development process. There were collaborations with pharmaceutical companies that prior to this point may not have ever worked together before. So for example, Moderna, which you guys know is one of the vaccine makers, it's actually relatively a small company. So companies like that had to partner with larger companies for mass vaccine production and rollout campaigns. The US government also secured hundreds of millions of doses of vaccine from many different manufacturers, even before they were or received emergency use authorization or could even be approved. So our government was actually thinking ahead. And again, at least with 6 different companies had already secured the rights to receive hundreds of millions of doses. HHS, or the Department of Human Services, created the requisite infrastructure, and they pre-purchased these allotments that I told you about. The reason why this was important is because the mortality rate in the United States was 1.8%. We'll compare that with, for example, influenza or the flu. The mortality rate for influenza is about 0.1%. So if you can see, it's almost 20 times the mortality rate in the US. and worldwide, it's even greater than that. So the AstraZeneca and Johnson & Johnson vaccines, these particular vaccines utilize deactivated virus or some form of live attenuated virus grown in a culture that will weaken the virus. And so our immune system, our B cells in the body will synthesize and store antibodies against the surface proteins found on the viral capsule. And the host immune system will mount an adaptive response in the event we encounter a live version of the virus. And this is what that process looks like. So back in January, China, which is where SARS-CoV-2 was first identified, they released the blueprint or the genetic makeup for the coronavirus 2. And once they did that and released that information worldwide, companies began immediately trying to design vaccines that would actually combat the virus. So Johnson & Johnson actually went the more traditional route, and they looked at the vector vaccine, in which you take a snippet of one of the surface proteins and you inject it into some weakened form of a different virus, like an adenovirus, and you try to come up with an ideal candidate. So Johnson & Johnson actually began that process back in January, and they began their preclinical testing in March of 2020. With Pfizer and Moderna, these companies utilize what's known as the mRNA technology. So it does not use this altered whole or weakened virus. It encodes a messenger RNA with the information to produce the SARS-CoV-2, the spike protein, which is what the virus used to get into our cells. And then ribosomes inside our cells will then translate that messenger RNA into an excretable version of spike protein. These spike proteins are abundant on the surface of the virus, and they're necessary, like I mentioned before, to gain entry into the host cell. So this is what that particular process looks like. So again, you have your spike proteins, and there are various types of spike proteins, and you encode the messenger RNA sequence. You inject that into a lipid nanoparticle, you create vaccine, and the rest is history. So I won't cover too much with this slide, but just to let you know how quickly these companies who use the messenger RNA technology, how they develop these vaccines. So again, like I mentioned, the genetic code was released by China at the end of January. And these companies began immediately to begin their phase 1 and phase 2 clinical studies. So Moderna and Pfizer both did, well, Moderna was a little bit ahead in July 14th, and then Pfizer was in August, and both proved effective in vaccinated animals. And then with the phase 3 studies, what they found is that there were 170 confirmed cases in the COVID-19 cases, 8 in the treatment arm, giving an efficacy rate of 95.3%. And with Moderna, 196 cases, leading to an efficacy rate of 94.5. The great thing that we all need to take from these particular studies, because I know that this is a lot of information I'm throwing at you, is that last bullet point, that no patients require hospitalization. So requirements were 30 over 100, or excuse me, out of 185 versus none. So again, no one developed severe disease requiring hospitalization, and no one died. And so to have a vaccine of any format to come to fruition this rapidly with this particular efficacy data was phenomenal. And just so that you all know, in comparison, the influenza vaccine, we are happy, and the FDA would have been satisfied with these COVID vaccines if we achieved 50% efficacy. So 95.3, 94.5 is phenomenal. It's exceptional, and we were not expecting that. So it doesn't mean, however, that you won't contract SARS-CoV-2 or coronavirus. It just means that you won't have to go to the hospital, and you won't likely die from it. So how do the vaccines compare? All right, so I have, this slide shows you the various companies and the technology that's used. I won't go into that. As we mentioned before, the Johnson & Johnson, as is the AstraZeneca vaccine, which we actually have doses here in the United States. Like I said, our government actually planned. We didn't know which of the companies would, their vaccines would make it to market first. So we just bought hundreds of millions from each of them. So There are AstraZeneca doses that are available, that there are companies here in the United States that are mass producing them, but they haven't even received emergency use authorization. And the theory is that they would likely just submit all of their data for full approval and not go through the emergency use process. But again, AstraZeneca, very similar to Johnson & Johnson. They're viral vector vaccines. Pfizer Moderna, again, the messenger RNA. The efficacy rate, you can see that Johnson & Johnson is lower at 66% compared to 95% with Pfizer and 94.5% with Moderna. The thing that I want you guys to keep in mind here is that because the other two, that being the messenger RNA vaccines, got started earlier than Johnson & Johnson as far as their clinical testing, their efficacy rates appear higher. Because I get asked this question a lot. Well, would you choose Johnson & Johnson? Well, Johnson & Johnson, because they got started later in the process, we believe that a lot of their data involves the use of the vaccine or the study or testing of the vaccine when variants, a lot of the variants were available. So like the Brazilian variant, the South African variant, and even the UK variant. So again, that efficacy rate takes into account the presence of variants. The storage, the thing to take home from that is that the Pfizer vaccine requires the rapid cold chain storage, the ultra cold storage, compared to Moderna, where you need that too, but it can be refrigerated for up to a month or at least a month. And this information is continuously changing because these companies, even though we received emergency use authorization for these vaccines, they're continuing to test these vaccines to see if we can, for example, get more doses out of a vial, or if we can store them longer and them still remain stable at either refrigeration type temperatures or even at room temperature. Johnson & Johnson, one shot, one and done. And that's very, very important because we have vulnerable populations who could benefit from Johnson & Johnson. Those vulnerable populations are the homeless, and we see a lot of those patients at our hospital, at University of Illinois Hospital, because we are the safety net hospital for the state of Illinois. So we get people that come here from everywhere. So again, it's one and done. In addition to the homeless, the homebound. That would also be a scenario where the Johnson & Johnson vaccine would be ideal. The other two require 2 doses, Pfizer 3 weeks apart, Moderna 4 weeks apart. And the thing to keep in mind is that these vaccines have received emergency use authorization, although we think that Pfizer might be FDA approved first because they are preparing their paperwork for submission. As it relates to the vaccine ingredients, because I get asked questions about this all the time, well, what's in them? And I can tell you what's not in them, and that is microchips, okay? So you don't have to worry about state, local, or federal government monitoring your whereabouts because chips are not located in them. Basically, it's the messenger RNA that we have been talking about previously, wrapped in a lipid nanoparticle, and then there's salt, sugars, and buffers. That's really about it. So the reason why I have a circle around the PEG or polyethylene glycol solution, this is for the Pfizer and the Moderna vaccines, is because we think that those particular compounds has resulted in anaphylaxis or the allergies that have been seen in some people. So it's that particular compound. So if you know that you have an allergy, we call it PEG, but it's polyethylene glycol, then you probably should undergo allergy testing before receiving the vaccine. The side effects. There are several side effects that can occur. Different people will experience different ones. The ones that I have circled are the ones that I experienced. After the first vaccine, I think I might have felt a little bit of lightheadedness, about an hour or so after the vaccine, but that was it. It just went away. But some people complained of sweating, clammy skin, feeling facial warmth. Also, people felt or complained of pain or erythema at the injection site. We're finding many more incidents of cutaneous reactions at this point. So more people are developing rashes and things of that nature. And the FDA has said that it's not a reason to not receive the second dose if you receive that rash after the first dose. This is just more information about the types of symptoms that people might experience. Things, again, that would preclude you from getting the vaccines is having an anaphylactic reaction. So shortness of breath, closing of the airways, syncope or respiratory collapse. And we do have medications available for people who receive the vaccine to treat them if this occurs. So typically it's epinephrine, and there might be Benadryl and the steroid involved. But again, for patients with a strong history of anaphylaxis or severe allergies, the recommendation is that they wait 15 to 30 minutes post-vaccination, as opposed to the other less or more common but less severe symptoms where you only have to wait 15. As it relates to the anaphylaxis, what we know is that for Pfizer, the rate is 10 to 12 per a million persons injected. With Moderna, it's less than that at 2.5 per 1 million. And for vaccines in general, just so that you guys can compare, it's 1.3 to 1 million. So what about this vaccine-induced thrombotic thrombocytopenia? It's been in the news a lot lately. And basically what it is, it's known as VITT. Very similar, if you work in healthcare, to a phenomenon we call HIT, or heparin-induced thrombocytopenia, and we've seen it with the viral vector vaccines. So AstraZeneca, so they're having problems with this in Canada, but also the UK, and then also in India, where AstraZeneca is widely distributed. But here it's not being distributed, but we do see this with Johnson & Johnson. And it's an immune-mediated platelet and clotting formation that occurs. So patients are getting blood clots in the extremities, in the abdomen, but what's more severe and really uncommon in the natural world is they're getting clots in the brain, okay? The incidence is 1 in 100,000 for Johnson & Johnson. So far, there are 17 cases, but this is out of 8 million doses administered. Most were women, and one of which passed away. And this slide just makes reference to some of the symptoms that someone might experience if they're experiencing VIT or VITT. So on the right, you see severe headaches, seizures, because again, like I mentioned, that what's severe about these particular clots is that they occur in the brain. And you can see that it occurs 4 to 28 days after the vaccination. So other questions: how long do the COVID vaccines provide protection? Great question. The answer is we don't know. Pfizer thinks that their vaccine remains highly effective for at least 6 months, and they're basing this information on antibody titer data. So they're measuring the amount of protective antibodies in people. You have to realize these studies were conducted for 6 months. So we truly don't know how long that protection is offered. We are still following people who were in those original studies, and so they're going to continue to measure those antibodies and see if declines in antibodies levels still confer an immune response. Are the COVID vaccines effective against the variant strains? Pfizer says that their vaccine is, but so does Moderna. And we do know, because Johnson & Johnson was actually studied in other countries, that being Brazil and South Africa, that there is a degree of protection with that one as well. Another question that we're asked a lot is, will we need a third dose? Pfizer and Moderna both say that we do. I understand why they say that we do. I think that they would love to be able to have to administer or create another vaccine for us. Again, the true answer is that we don't necessarily know if we'll need a booster dose per se, but this is what we're thinking. We know that 108 million Americans have been fully vaccinated, and that they're currently indicated for everyone 12 years old and older. There are some vaccines like polio where one dose is enough, but others like the flu vaccine, you have to get those annually. So Pfizer has begun to test. They started this in February to see whether a booster is necessary after 6 to 12 months. Moderna announced their booster development also. The rationale for a booster is to increase the titers of those protective, or I call them neutralizing antibodies. Also, we know that we have breakthrough cases of COVID, and even we've had a death in patients who were transplant patients who were on immunosuppressant agents. And then we also know that the rationale would be to provide protection against the variants, and the most common ones be UK, South Africa, and Brazil. The new CDC recommendations, really quick, we've talked about this, is that authorization for those as young as 12 to 15 years old, although Pfizer and Moderna are conducting trials in children as young as 6 months old. In pregnancy, the CDC is reported there's growing evidence confirming the safety of COVID vaccines during pregnancy. Pregnant women were not enrolled, but women did become pregnant after receiving the vaccine and while they were enrolled in the study. And so far, not only have things worked out, but we found that there have been helpful antibodies found in the cord blood for women who were pregnant at the time that they received the vaccine. Vaccine passports. This is something that's coming. It's a real thing. I don't know what it will look like, but there probably will be a process by which we're trying to determine who's received the vaccine or who has a negative COVID test. And so as you can see, these are headlines. Chicago to offer a Vax Pass next month. And this was written in April the 30th. Also, the very first citywide festival is going to be the Windy City Smokeout. So if you like country music and barbecue, the city is already planning to do this. They added an extra day. But where might we use a Vax Pass? For international domestic travel, healthcare workers, also those who work in the front line, like grocery store workers or transportation, like CTA workers, universities and colleges. It hasn't hit with the public university systems across the country, but it has with several private colleges. We're in upwards of 120 colleges or so, private institutions that have actually required students get vaccinated before coming back to campuses. Concerts, festivals, and sporting events. And again, those might be a one and done, like a Johnson & Johnson might be quite ideal for those type of events. Vaccine hesitancy. I won't talk about this because my colleague, Dr. Floyd, is going to talk to you guys a lot about that. And these are just some of the headlines that we've seen. So there are different groups within our community that have hesitations about the vaccine, that need more education, that have concerns. There's also issues with uptake. And again, Dr. Floyd will get into that. My final thoughts as it relates to the vaccines is that vaccines don't save lives, vaccinations do. So get your jab today. And as opposed to opening up for questions, I think we're going to save those to the end. I'm going to turn over or stop sharing my screen so that my colleague can begin. Dr. Floyd.
Yes, thank you so much. I am going to share my screen now. Give me 1 second. All right. Can everyone, oops, I'm sorry, I just hit stop. My bad. All right, here we go. Can everyone see my screen?
Yes.
Yes, I got to see some thumbs up. Okay. And I'm going to trust that you all can hear me well.
Yes, thank you.
Great. So my name is Brenikki Floyd, but most of my closest friends and loved ones call me Nikki, so feel free to do so. I'm a clinical assistant professor in the School of Public Health. I'm in the Community Health Sciences Division. And I've been here at UIC for going on 10 years, starting as a postdoc and arriving in my current appointment. So I'm delighted to be with you all today and sharing a bit more about the COVID-19 vaccine from a public health perspective. So what I'm planning to talk about in our time together is COVID-19 vaccine impact with a focus on uptake, vaccine hesitancy, or many of the other terms that are used when describing this phenomenon, deliberation, for example. I'm going to talk a bit about misinformation and myths, and then tell you a bit about some work that I'm doing related to COVID-19 here in Chicago. So I may not see your comments in the chat, but feel free to do so, to include them. So here's a picture of me getting the vaccine. think I got my second dose like the second week in February. And this was actually one day before launching our COVID-19 street outreach program, which I'll tell you a bit more about it. And I'll filter into our talk the different emotions and processes that I went through during this process. But in keeping with talking about the vaccine, and just to build off of my colleague, Dr. McPherson, we know that the COVID vaccine can reduce your risk of infection. And it does not prevent you from getting COVID, but it definitely protects you from having severe symptoms, right? That is one myth that I hear people say periodically as well. I know someone who got it, or it's going to give me COVID. But we know that the more people that we can get vaccinated, the closer we are to reaching herd immunity, which thus reduces our chances of getting the disease. But also, similarly to the way that we've been practicing COVID safety behaviors like wearing a mask and practicing physical distancing or social distancing and washing our hands, getting the vaccine will help protect the people who are around us that we care about from getting severe illnesses. And we know that there's certain populations that just with the exposure to the virus and contracting COVID, the vaccine can help to make their outcomes better. So for example, with older adults, we know that 8 out of 10 COVID deaths reported in the US have been among individuals who are 65 years of age and older. But we also know that your risk for it increases with age, and obviously with older adults being that highest risk group. But I wanted to show this table, and I'm sorry for not citing the CDC, but this is a depiction of how our risk increases with age, which helps us sort of understand to some degree why some people are quicker to uptake the vaccine versus those who are delayed. So we see here that if we look at death, individuals who are 85 years old and older are 8,700 times more likely to die due to COVID, compared to folks in the 30 to 39-year age group who are 45 times more likely. And this trend, we see this as well with hospitalizations, right? I'm going to talk a little bit about age. So put a pin there and bear with me. COVID, these are just a sampling of some of the medical conditions that increase the chances of having severe illnesses if you were to contract COVID. We see cancer, which Dr. McPherson mentioned a moment ago, and heart conditions, which once ranked as at one point in time, the top health conditions that have had a really significant impact on certain communities. Diabetes, substance use. You see here immunodeficiency, and that's related to primary and secondary. Primary meaning a deficiency that's related to a genetic predisposition, but then secondary immunodeficiencies are also related to some medications that we sometimes take, like steroids and whatnot, right? So there are a lot of different populations is what I want to depict here. We're looking at health conditions, but I don't want to just categorize this as just people who have cancer, but these are individuals that really make up these different groups who have an increased risk for COVID. Well, we were thinking about, transitioning from, not having protection via the vaccine to getting fully vaccinated. I found data through our Illinois Department of Public Health that was updated as recent as May 5th that gives us an image of or depiction of the population who are fully vaccinated. I didn't include data for, by dose, whether it was one dose or not, but we see here that in Chicago, this is like about 35% who have gotten fully vaccinated. In Cook County, this is somewhere upward about 37. And then for the state is somewhere at 34, 35. So very, very similar in the rate of those people in our state, in our city, in our county who are fully vaccinated. And that is sort of with the hope that this is an upward trend. However, we know that that's not always the case. We've heard a lot of discussion about racial and ethnic disparities when it comes to COVID. And I wanted to sort of pause for a second to introduce my personal lens. It's a lens I hope everyone will take up, but I tend to see the world through a health equity lens. And the work that I do, the teaching that I do, the research that I do, all comes through this health equity lens that says, sorry, here's the definition. I got one of my slides out of order. And for those of you who, this is maybe a refresher, this may be new to some folks, but health equity, there's a number of ways in which it's defined, but here's a nice definition from the CDC that just basically says health equity is achieved when every person has the opportunity to reach their full health potential, and no one is disadvantaged from achieving their full health potential, due to their social position or any social determinants in their environment. So that's, by race, by gender, sexual orientation, gender identity as well, SES, where you live, right? So I think of COVID-19 as many other people are doing in the context of health equity. And we see that as, in terms of, expected life expectancy and quality of life, severity of disease, access to treatment. But one of the things I want to also mention to you is that access to health information is just as important. I do have a slide on social determinants because that's also part of the lens. But when we're thinking about the uptake of the vaccine, when you look at the racial equity, ethnic disparities, and in the context of health hesitancy, people oftentimes will think about hesitancy meaning that a person is refusing to take the vaccine. And I just want to introduce another way of thinking about this in terms of it not necessarily being about refusal, because refusal and hesitancy specifically can be really complicated. This could be a matter of dissent. The literature is starting to flesh out different ways of thinking about why certain groups of people are getting the vaccine versus those who are not, right? We know that the impact is severely impacting, people of color, disease burden among Asians are on the rise, but deliberations sort of means that people are taking their time. You may have heard the phrase wait and see, as some people might be in that category. I, for one, for a long time in the wait and see category. I started doing research on the vaccine largely because of the work that I do, but for personal perspectives, I needed to know more. I was at that point where I felt like it was too soon, it was being rushed, I don't know enough, right? And I was also in the mind frame of, I want to get it, I'll get it, but I might not get it right now, right? So professor out of the University of North Carolina, Dr. Kobe Smith, introduced in an article that was written, published in The Lancet earlier this year, where she talks about vaccinations and liberation, where for people of color, specifically Black and Brown people, this is a time of watchful watching, being mindful of the skepticism of a system that has already demonstrated inequities and social and structural racism. And so part of what this narrative is talking about is how vaccine hesitancy is also rooted in structural racism. And sometimes people are not really calling that for what it is. It's a matter of mistrust. It's not that I don't want to get it or refusing to get it, but there's a system that has invoked some historical trauma in certain populations in the past, and I haven't forgotten that. So I need more. I need more information, or I need to feel like I trust the institutions that are providing this information. So here's a breakdown, right, of vaccines uptake by race and ethnicity in Illinois. And what we see here is among Asians, the percentage is about 7%, 9% for Black people. For white people, the vaccination rate is 68% in Illinois. For others, that's 3%. Hispanic is at 12%. And then the American Indian and Alaskan Natives and the Native Hawaiian and Pacific Islanders, that's less than 1%. And that's between December 2020 to May 3rd. Why is this happening is the question, right? So I want you to think about, when you see disparities, don't think of this in terms of there are people who are refusing to get the vaccine, because that's not always the case. There are studies that are coming out that are looking at different groups of people. For example, by political affiliation, where Republicans are less likely to take up the vaccine. We see that older working age adults, in certain industries are less likely to take the vaccine. A study was conducted that looked at vaccine intentions among incarcerated individuals. And we also saw similar trends here where Black and Hispanic people incarcerated were less likely to have intentions to take the vaccine. And so what are some of those reasons for hesitancy? Well, people are wanting to make sure that the vaccines are safe and that they're proven to be effective. The Kaiser Family Foundation, which is a great resource if you were looking for information about what the communities across our country are thinking and doing in terms of uptake with the vaccine, there's a lot of great data there. So I pulled some charts that they have on their site that looked at enthusiasm, and it shows how at one point enthusiasm was high among certain groups, but it declined over time. And so I'm going to walk us through this by race. So pay attention to the wait and see group. Again, I once identified with that group, right? So this is the total for all race and ethnic groups. And as we go through by race, we see that the enthusiasm among Blacks declined from 60% in December to now about 20%, right? So this is before it came out, before the vaccines were started to be distributed. And then a lot has happened, like Dr. McPherson mentioned, the issue with Johnson & Johnson, the media's role. Let's look at the Hispanic population. So their trends also saw a decline, where we went from about 40% to now about 18%, right? And these are the folks who are in the wait and see group, the people who have a potential to have their decisions changed at some point. And then among the white group, this wait and see group is now at about 13%, where previously we were looking at about 40%. So what's happening, for these declines, if you will, in enthusiasm? Well, there's a number of reasons. And it depends on the group. It depends on the population, the person you're speaking to. For the people who are in the wait and see, some of what you will see here on this table, Dr. McPherson mentioned as well. People are wanting to see more people get the vaccine in order for them to make a decision whether they want to get it. There's not enough research, or there's not enough research that included people who look like them. There's some people who just flat out just don't want it. Concerns about safety, side effects. I can relate to each of these things. Just to give an example, my wife first started talking about interest in getting the vaccine about, early January. And I was expecting her to get it because she's a medical provider. So when she got it, I was asking her questions like every day, how you feel? What are your side effects? Check to make sure she can grow a third eye, right? I kid, but I literally was, observing. And then people in my network and in my social circle, the more we talked about the vaccine, we were doing the same thing. You know, we were like, hey, did you get it? I think I got it before several of my friends because of my job, and I was able to share with them what my side effects were. I got Pfizer version, and I literally had little to no side effects, but I was able to share. And I noticed many of my colleagues, we did the same thing. So I hear more and more people are saying, you know, they want to see more people get it and that it works. They want to know more about the side effects and know what to expect. They want to learn more in terms of, you know, the research and why there's not enough research, you know. And don't be confused with, you know, these things being in vacuums, because some of these issues are related to, you know, historical things. For example, not enough research. Well, there's been a lot of mistrust and trauma in medical research. And so people of color are less likely to participate in a clinical trial, right? So it's kind of comes back full circle. But then, you know, for people who are really eager to get the vaccine, you know, there are reasons why they can't get it as well. And this goes back to some of the social determinants of health, like work, you know, not being able to take off from work, transportation, not having, you know, proper documentation, or not even being aware if they're eligible and when they're eligible, and then, you know, a lack of information about how to go about getting an appointment to get the vaccine. And so when we're thinking about those social determinants of health that I mentioned before, you know, this is just a list after, you know, reading a lot of articles and about vaccine equity, like what is keeping people from getting the vaccine if they want it? Or what are some of the things that are that would potentially make a difference for people to get the vaccine if they want it? The age minimum for the vaccination. So remember in the slides before where I talked about how as age increases, your risk increases, right? But we had a rollout process that focused on seniors, right? But some would say that some of the age minimums should have been lowered for racial and ethnic groups who are known to have more severe outcomes due to COVID, you know, hospitalizations and deaths, for example. Scheduling appointments, you know, I know that some communities in Chicago were using, what is it called, Q codes, I think is what it's called, Q codes to schedule their appointments. Sometimes appointments were, you know, scheduled online or maybe phone. I've heard different things about that. And if it's an online appointment process, you know, the digital QR codes, thank you, Dr. McPherson, QR codes. The digital divide still exists, right? And so though most Americans have a cell phone of some sort, it doesn't necessarily mean that they have good access to internet or they're able to navigate the internet to do certain things like, you know, schedule vaccine appointments. Then there's language barriers, materials, you know, not being sufficiently provided in other languages such as Spanish and, you know, Polish as an example. I've read articles that shared accounts of people who, you know, traveled a good distance to get the vaccine, only to arrive and be told that they needed to produce certain documentation that they did not have. And this is, you know, this particular instance is an example that was related to an immigrant woman. And then access to vaccination sites and transportation and other, you know, planning things. So we have to be mindful that the social determinants of health, that in the ways that we think about them, where we work, where we live, where we play, that these structures, you know, and these conditions not only have an impact on our health, but they have, you know, impact on our access to health and access to information, which, you know, is a important part of accessing health information and health services. So I want to just talk a little bit about myths, kind of building on to what Dr. McPherson mentioned. You know, we are currently living in an infodemic as well as this current pandemic. And the infodemic is described as an overabundance of information, whether some is accurate, some is not. But all of this information, this cluster, this noise, makes it hard for people to find information that's trustworthy and reliable in terms of resources and getting the appropriate guidance that we need. So I saw this article in Policy and Ethics that I really liked when I was preparing another presentation, and I just wanted to include it here, where COVID misinformation is killing people and this epidemic has to stop. So you're thinking about getting information from your family and friends, from social networks, your media platforms, your doctors, CDC, and I honestly haven't done the research lately, but at one point people did not trust the CDC, and some of it was related to their guidance, from our federal administration. And Ruzan, I see you have a question. If you want to ask it, feel free. You can drop it in the chat if it's related to this. And so with this infodemic, there's a couple things that we have to be mindful of. There's misinformation and then there's disinformation. Misinformation is just having a lack of full understanding, of the virus, or in this case, the vaccine. Disinformation is when you're deliberately trying to spread false information or be misleading in an effort to influence the public's opinion or deceive them. And we saw a lot of that throughout 2020. And this is a topic that I could spend an entire semester talking through. So if there's any question you want to ask me to go back and elaborate on something, feel free. But what I want to know from you all is, what are some myths that you've heard about related to COVID-19 vaccine? And feel free to drop them in the chat, and I'll look through them as well as I go on. And Dr. McPherson just added, this is currently being studied. The CDC currently says that vaccines are not interchangeable. Yep, thank you for that. So feel free to add your myths that you've heard about this vaccine. Someone says, I understand that, but I'm not sure what to do about these patients clinically. I have extended family worried the vaccine gives you COVID, which I've tried to combat. Thanks, David. The vaccine, the computer chip in the vaccine. Any information on what to do with patients who have gotten one vaccine outside the US and travel outside the other? Excellent. But those that are not related to myths, we'll come back to that during our Q&A if that's okay. But thank you all for adding some of these myths that you've heard about in the media or in your circles.
Dr.
So here are some myths.
Oh, I'm sorry, I didn't need to jump in. I just wanted to check in and make sure we're okay with timing for both you and Dr. McPherson. We're fine on our end.
Oh,
just want to make sure that you're okay.
Yeah, I will wrap up. Thanks for.
It's so interesting. We talk about this for hours. So I'm sorry to interrupt. I just want to make sure you're okay with timing.
No, you're excellent. I'm gonna wrap up soon. You're fine. Okay. All right. So these slides will be shared with you all, and these are myths that you've heard before. Some of which Dr. McPherson has already covered as well. I'm not going to go through them all, but the point is that we know we're living in an infodemic in addition to the current pandemic, and that we have to get educated and informed so that we could not fall into certain landmines when it comes to being exposed to the wrong information that can lead us down the wrong path. So I wanted to spend a couple of minutes sort of talking about some work that I'm doing that's related to getting the community accurate information about COVID-19, the vaccine, and also giving them resources to protect themselves. So I am the lead of a program, for lack of a better word, called UIC, COVID-19 Street Outreach Program. And what's unique about this program is that we received funding from the Chicago Cooks Workforce Partnership. And they got funding from the state, who got funding from the Department of Labor. And the intent of these monies is to provide temporary employment relief to people whose employment was impacted by the stay-at-home order that the governor issued this time last year. And so there are several grantees who receive the subcontract from the partnership. And so our team, this is a picture of them over here to the right. We go out into the community and we pass out masks, hand sanitizers, provide health education information around COVID and the vaccine. And we're also partnering with different community partners, which I have a few listed on the screen here, some with UI Health, Mile Square, but some out in the community, CBOs. And these are actual pictures of my team members who are out in the field, working with the community, giving them information, giving them masks, answering their questions. A recent collaboration with UI Health, we got involved with them about the time that the vaccines were being distributed, and UI Health had a mass vaccination event for Inglewood that we joined forces with, and my team went from doing the types of things I described before to actually helping people get scheduled for their vaccines. The scheduling process required people to use QR codes, and some of the communities throughout Chicago, though they had, like I said, they have computers, they have phones, but they didn't know how to work a QR code and how to get through that process. So, they're out there helping them in that way. And so, in addition to this program, it's a temporary job. It's 12 weeks. I was able to extend their time with us to the middle of July. And so part of their work, we do earn and learn sessions to help build their capacity so that when their temporary jobs are over, they've built some capacity as they're in their current outreach position to help them go on to get permanent employment or go back to school. And so I asked them on 2 weeks ago during one of our earn and learn sessions, what are we hearing in the community about COVID? And here are some examples of what people said. And these are very similar to some of the myths that we talked about previously. It's not FDA approved. I'm not taking it. I don't need the vaccine because I'm the cure. I eat healthy. Mark of the beast, And so my team has been able to, combat the misinformation and the myths that they've been hearing based on the training that we've provided. But I just want to close by, wrapping this up to say that it's really important that we make sure that our communities have access to accurate health information and resources, including the vaccine, and in a timely manner so that they can empower themselves to be safe. So that is all I have. I think now is a great time to go to questions. Sorry, I'm a little long-winded.
No, thank you, Dr. Floyd. Thank you, Dr. McPherson. This has been so incredible. And thank you for all the incredible work you are doing out in the communities and just every day at UIC. I say this with sincere heart. I'm so proud that you're on faculty, and I'm so proud that you're part of UIC, and just thank you for all this wonderful work. I think Dr. McPherson has been answering most of the questions in the chat. I'm just going to check with the team. Oh, there we go. Just check with the team, make sure we didn't miss anything. And Dr. McPherson, I think that you've been answering them, is that correct? Yes.
Yes, I have, to the extent that I'm able to.
Okay.
There's some really, really good questions.
Well, and I think you did an excellent job of saying there's still a lot we don't know, and that it's changing every day. And you both have talked about how this is just evolving, constantly evolving. So great. Well, thank you. I do want to be sensitive to time, and I do want to thank both of you for your wonderful presentations. And since I think the questions were answered, I think I'll go ahead and just say thank you. And if there's anything else, the slides will be available and everything will be online, a copy of this recording. And certainly you can always write to the UIC Alumni Association if there was additional questions that we missed by accident. We'd be happy to share those with our presenters and try to get answers if there are answers. Okay, great. Well, thank you again, Dr. Floyd and Dr. McPherson. We really appreciate all of your time and your knowledge. Just to close out real quickly, please join us next week for our next Alumni Exchange program on Wednesday, May 19th at noon Central Standard Time, as we will be joined by Carol Peterson, who is the Director of Health, Education, and Wellness at UIC, as she presents stress, burnout, and self-care, and shares ways that we can manage stress during this time and how we can recharge. To find recording of this episode or any of our previous episodes or upcoming episodes, please again go to go.uic.edu /alumni exchange. And of course, please be on the lookout for that quick survey that I mentioned at the beginning. We certainly value your opinions and thoughts. Thank you again to both of you for being here, for sharing all this incredible information. We really, really appreciate all of your time and knowledge. Thanks to all of you for joining us in the UIC Alumni Exchange, and we look forward to seeing you again soon. Thanks so much and have a great afternoon.